We have talked so much on this program and on this network about the crisis, the epidemic involving opioids in this country. Well, now there's an interesting study that looked at whether over-the-counter medicine like Tylenol or Motrin, acetaminophen, ibuprofen, could those be just as effective in treating pain as a prescription opioid? A new study published in the Journal of the American Medical Association suggests a big change could be needed in emergency rooms across the country. It's something we've been talking about, and took a look at whether using those over-the-counter pain relief medicines that you may use at home could treat severe pain as well as opioids. And they specifically use these on folks who had just broken a bone. We're going to take a closer look at this study and also what it could mean for you, what it could mean for the number of people who become hooked after being prescribed drugs for pain. Joining us now with more, Dr. Devi, Associate Professor of Rehabilitative Medicine at NYU here in New York. Well, Dr. Devi, as we look at this, we've talked so much, and you're a specialist in pain medicine, I should point out. We've talked so much about overprescription of prescription opiates, giving you 30 Vicodin for a root canal. Could something like Tylenol or Advil be used just as effectively?
I think it can in certain cases. So, I'm just as much in favor as other folks of decreasing the amount of opioids out there. But I have some concerns about this study. So for example, one of the issues we have with overprescribing is that people get too many medications, perhaps too many tablets. Sometimes the medications are too strong, and sometimes they get these medications for conditions that don't necessarily benefit from opioids. But in this study, when we're talking about people with broken bones, opioids are considered one of the standard treatment options. So they took people who had moderate to severe pain, either from broken bones or from other reasons, whatever the patient said. So that's a concern, because broken bones, if you fractured your arm, you fractured your leg, opioids are considered the standard. But if you have severe pain from other reasons, opioids may or may not help.
But even if that's considered the standard, should it be? I mean, because if we look at things at a certain point, and oftentimes, I will say, just based on my own experience and different people I've spoken with, it seems that when you're given these drugs, you're almost told to pre-manage your pain, too. So you never really get to the point where you're feeling some pain because you want to take that pill again so that you're not uncomfortable at all. And you're so drugged and knocked out, you have no idea what's going on. Do we need to start learning to feel a little bit of pain again so that we're properly prescribing?
Well, I think that you brought up a good point about how if you're knocked out and you're sedated, that's not the purpose of the medication, right? So there's a problem. If, on the other hand, our goal is to get people so they're functional again, right? So that they're awake, they're able to work, they're able to do exercise or physical therapy if that's appropriate. So those things, we have to weigh the risks and the benefits. So if someone has a broken bone and can at least use the medication to be able to get down that path, I think that's reasonable. But whether they have a broken bone or whether they have some other reason to have pain doesn't mean they should automatically be pre-medicated with these opioids. So I agree with you 100% about that.
Right.
In this study, the reason that I'm a little bit concerned about it is because I think the design was flawed. So if someone has a broken bone, we normally do give them anti-inflammatories, not just opioids. You can still use other things to try to treat the pain. But what they did was they compared the anti-inflammatory to opioids. So that's not necessarily how we should do things in clinical practice. We would give someone an anti-inflammatory anyway, and then if they could benefit from the opioids, then give them that as well, because not everybody will be able to manage a broken bone with Tylenol alone or an anti-inflammatory alone.
Right, and the concern, too, is that not everybody can manage that prescription that they're giving for a prescription opiate. We know a report from the National Academies of Sciences, Engineering, and Medicine found at least 8% of prescribed opioid pain relievers people end up developing opioid use disorder. 15 to as many as 26% then engage in problematic behavior. So coming out of that, as we're learning more and more about where this addiction for many people starts, and it starts oftentimes with a prescription, what are you noticing in terms of a change with your fellow physicians? Are they prescribing fewer pills? Are they thinking more about other options besides an opioid?
Yeah, so those are all things that are moving in the right direction. I mean, here, so in the ER, it's very difficult for emergency room physicians to figure out all of the details of what's going on. But if someone goes to the outpatient side afterwards, so let's say they get maybe 3 days of opioids, 5 days of opioids, or something like that from the ER for their broken bone, if they're still having pain, instead of automatically getting a new prescription or automatically getting a month's supply, instead they get evaluated. Well, let's see if there's some other problem that's been missed because this should be healing by now. Let's see what other treatments we can use instead. And let's see if there's other conditions that might predispose you to developing a problem. So we usually talk to other doctors. We get more tests if someone has other risk factors for a problem. So for example, if they're abusing other medications or recreationally using drugs that should not be used in combination with opioids, then we go in a different direction. If somebody has a psychiatrist or other doctors that have concerns, then we don't prescribe opioids anymore. Now New York State in particular has a registry, as do many others, where we can look at who else is prescribing the patient medications. So I think there are a lot more safety measures to look at these things than there were in the past. But my concern is still, if someone comes to the ER with an issue, you don't necessarily have time to do all of these things. So I don't think they should prescribe a long duration or a large number of pills. But if someone has a broken bone, it is reasonable to still prescribe them at least a couple of days of opioids to treat that.
It is a start of such an important conversation, one of many. Good to know, too, what New York State is doing just in terms of monitoring those different prescriptions. Dr. Devi, always appreciate your insight. Thank you.
Thanks.